the intrapleural space is this little cavity here. It contains a few dozen milliliters, so it's not a very big space. It wraps each lung individually. And because it's a closed space, the lung is basically held against the thoracic wall. Okay? The lung would like to collapse. The lung has lots of elastic tissue that would pull it inward, but it's being held open. It's being held basically glued against the wall of the thorax. Okay? And there's a condition where the space is compromised. Anybody know what that's called? Yeah, it's called a pneumothorax, where air makes its way into that space. Okay? So if we have, I like that clown, isn't he cute? If we have some damage that happens to the thoracic wall, excuse me, where air can get in, this space that I was talking about, this intrapleural space, becomes really big suddenly. Okay? And the lung tends to pull in on itself and open up that space. Okay? So that space, we usually just don't worry about it, the intrapleural space. The pleural cavity resides. Okay? But if we have a puncture from a knife, a gunshot wound, etc., we can have air air work its way into that space. Okay? And then we have what's called the collapsed lung. Okay? Collapsed lungs are not good. Okay. All right. So we've got to move on to bigger and better things. We've got a little bit of ventilation to talk about today. We've got a couple of factors we need to consider that relate to ventilation. Okay? One is that we have airways which are capable of changing their diameters. Okay? This is true of the trachea down to the bronchi, the bronchioles, etc. All the different airways up until the very end have some ability to change their diameter. Okay? So if we were to undergo bronchodilation, we would increase the diameter of our airways. Okay? And what would this do to resistance? Decrease resistance. Okay? So airflow would become would take place more easily. Okay? Or if we have bronchoconstriction, diameter goes down and the resistance goes up. Okay? So one of the things that causes bronchoconstriction is histamine, right, which is a chemical that we release whenever we find some kind of irritant present in the body. This can happen in our skin with mosquito saliva making its way into our skin. We have a histamine response, right? And it can happen in our lungs too. Okay, and asthma is one of those conditions that would cause excess histamine. We have bronchoconstriction and we have high resistance, making it difficult for air to flow. Okay, so we can change this because of an immune response, but we can also change this intentionally. Right? If you're exercising, what would you like to do to your airways? Yeah, it's intuitive, right? We want to bronchodilate, make it easier for air to move through your airways. Okay, so we have the ability to control this as well. Okay, so the airways matter, and the other big factor is this term compliance. Do you have a question?
Yeah, I had I'm sorry, but I don't see that. Is this PowerPoint not on the same time?
This I don't know. It's not. What about today? What about none of this? No. None of this? No. Okay. What about this? No. What? Did I put anything up? All right. You ask so much of me. Okay. 80 seconds. Somebody time me. No, not really. I thought you were going to ask me what compliance was. I'll tell you later. Compliance. Does anybody know what compliance is? Come on, Sakai. Okay, it's coming. All right, here it comes. Okay, it should be up on Sky now. Okay, anybody find it there? Okay. All right, so. Do I have to start over? No.
Yes.
All right, so we talked about the state of the airways. Okay, this is an important factor in ventilation. Another one is that we have this factor called compliance. And you're familiar with elasticity, right? And this is a very similar term, okay? So if I have a rubber band, okay, and I stretch it, and then I let it go, its elasticity is when it comes back, right? It snaps back to its original shape and size, okay? Compliance is the initial stretching, okay? So how easily does a material, or the lungs in this case, how easily does a material stretch when you apply a force to it? Okay? That's what we're considering with this term compliance. You can think of it as just stretchability. Okay? Stretchability. So, compliance is affected by several things. So one of them is the surface tension that's inside of our alveoli. Okay? So we all know what surface tension is when we see it on a flat surface, right? Little bugs, very small rocks will float seemingly on top of a layer of water. Okay. What's happening here is that, without getting too much in the physics of this is essentially because of the intermolecular forces between water molecules. Okay. So water molecules will attract each other, and in a three-dimensional solution like we have anywhere except at the surface, anywhere in the depths of water, water molecules will be spreading out their interactions among cells all around them, right? Above, below, right, left, all the way around. But at the surface, where we have an interface between that water and air, there are no molecules of water for those water molecules to interact with, okay? So there are no water molecules to spread out the forces, right? So what happens is that greater forces exist within the plane of the interface between water and air, okay? So that increased tension is there, that increased intermolecular forces is there at the surface, and it makes it hard for things to break through, right? Okay, so how does this bear on lungs? Well, lungs are at 100% humidity, and there's a thin film of water that coats all of the internal surfaces of our airways. Okay? Now, when it comes to your alveoli, we've got all of these little intermolecular forces pulling inward on one another, but because it's arranged in a sphere, the end result is that there's a tendency for that alveolus to collapse. Okay? So there's tension on the walls of the alveolus that pull it in the direction of collapsing. Do you have a question? Is there a question? No? Okay. All right, so this surface tension is here, and it pulls the alveolus closed, or it tries to. That's the direction of the pull. Okay? So does this work in the direction of a high degree of compliance, or is this working against compliance? Yeah, this works against the ability of the lungs to stretch. Okay, it's pulling the lungs inward. Okay. Now we have this substance called surfactant. Who makes surfactant? We all do. Okay. What cells make surfactant? Yeah. Type 2. What do we call them? Alveolar cells? Okay. Sometimes we call them pneumocytes, which is a great name. Type 2 alveolar cells are the ones that make surfactant. And what this does is it mixes these molecules. They mix in, they sit at the surface, and they break apart some of the intermolecular forces that exist between water. Okay, so it doesn't eliminate surface tension, but it diminishes it. So with surfactant, we have a low degree of surface tension. Without surfactant, we've got a very high degree, and that alveolus will probably collapse. Okay, so we all make surfactant. We all have type 2 alveolar cells. You know who doesn't have a lot of surfactant? Premature babies don't have a lot of surfactant. And when they're born prior to something like 25 weeks of pregnancy, there's not enough surfactant there, so that that infant is really struggling to open up its airways. Okay? Or the alveoli are collapsed, and there's a tremendous amount of surface tension working against inflation of that infant's lungs. Okay, so this is one of the reasons that premature infants at that age, 25 and younger, have a much lower chance of living. Okay. Beyond that, when surfactant's present, then they have a much greater chance of living if they're premature. Okay. So surfactant is a really important thing to reduce this property of water, and that it's high temperature. Okay. And we also have the other tissues of the extracellular matrices that exist within the lungs. And one of those is elastic fibers or elastic tissue. And you can sort of imagine this like wrapping a rubber band around a balloon. Okay? So balloons want to collapse anyway, right? Balloons have a high degree of tension already. But if you wrap rubber bands around it, right, it's going to want to compress even more. And so our alveoli do have elastic tissue there that we have to work against when we inhale. Okay, so here they're shown in green, if that's not clear. Right, so the elastic fibers have to be expanded and stretched, okay, when we inhale. But they help us, right? When do they help us? When we exhale, right? So they help us exhale passively, right? So whenever we inflate our lungs, we have to fight against this elastic tissue, and we also have to fight against surface tension. There is some fibrous tissue here that helps to keep our lungs from stretching too much. But mostly this is not really an important thing until we get fibrosis. Okay, so fibrosis is a condition that can happen in any of our tissues, but basically it's essentially the buildup of fibrous connective tissue, which is collagen. Right? You guys remember collagen? What's collagen good for? Resisting stretching. Okay? Yeah, so it has high tensile strength, if you know that term. It resists stretching. Okay? So ordinarily, we can stretch our lungs without running into the limitations of fibrous tissue. But with certain disease states, fibrosis, too much connective tissue, and we can't really expand our lungs. Okay. And then last of these that affects compliance or stretchability is the flexibility of the thoracic wall itself. Okay, so we've got a diaphragm that moves and increases our thoracic volume, right? But remember, those accessory muscles move our ribs and our sternum. Okay. Here's a picture showing you your vertebra. All right, so here's a vertebra. Okay, see that? Vertebra. It's like an octopus or something. All right, so that's a vertebra. And what are those things next to it? Ribs. Okay? So how do ribs move? Well, they form joints with the vertebra, and they have to glide past the vertebra in order to move. Okay? So when we pull on those inspiratory and expiratory muscles for forced inspiration and expiration, we're moving these joints. Okay? Another reason not to get old, osteoarthritis can affect these joints. Okay? So people who have osteoarthritis can encounter difficulty in breathing because they have an inability to move their thorax effectively. Okay? So it works along with the surface tension and these elastic fibers that resist volume changes. Who wants to get old? Nobody. When I was a kid, I wanted to be retired when I grew up. Total type A person. Oh, sorry, it's so small. All right. So here we've got emphysema. Anybody heard of emphysema? Yeah. Okay. So let's see emphysema. Which of the following would describe the effect of emphysema on the respiratory system? Okay. So let's see what you can work through here with someone close to you and see the right answer. Okay. I'll give you 2 minutes. It's not locked anymore. Very demanding today. Put the slides on. What am I? Hey everybody, are we good? Anybody need another 10 minutes? 15 minutes? Okay, how about now? You ready? Need another minute? All right, I think we're good. All right. Okay, so the alveoli would enlarge, according to this. Why would alveoli enlarge? Do what?
the tissue wouldn't be there anymore to like press down.
All right, the elastic tissue is squeezing down on those alveoli. If we remove that inward squeezing force, the alveoli expand. Okay, that is the correct answer. Bronchoconstriction. Was that a guess, or is there something that can clear up? Now's the chance. Okay. Who would you pick? Last one. Yes.
Could you explain
Go ahead, explain what?
why it's not bronchoconstriction?
Why it's not why would it be bronchoconstriction? I don't know. Did you pick it?
Yeah.
Okay. You still get a participation point. Cool. So tell me, why did you like bronchoconstriction?
Because I thought it meant less compliance.
Okay. So the compliance of the lungs, that's a great question. So you said there's less compliance, so why wouldn't they expand? The elastic tissue is primarily around the alveoli. Okay, so the closing of the lung is something that the elastic fibers do primarily to the alveoli, or wrapped around the alveoli. Okay? And most of the lung volume is alveoli. Okay? The airways comprise very, very little of the lung volume. So the effect here is that we're reducing the force on the alveoli, not so much on airways. Yeah.
Can you explain why surface tension is effective?
Why surface tension is not effective? Okay. Surface tension is the inward force that's provided to the alveoli from that thin layer of water. Okay, so the elastic tissue works in the same direction, but it's distinct from surface tension. Okay, so there's tension overall, which comes from the elastic fibers and surface tension. But surface tension is distinct from the force provided by the elastic fibers. I'm glad we worked with that now. Cool. All right, so briefly, we need to talk a little bit about control. All right, so we all have brain stems, and in our brain stem, we've learned about that we have centers for controlling heart rate and states of vasoconstriction and all that. Well, no surprise, we have a place in our our brainstem that controls respiration, ventilation, I should say. So the ventilation control involves some nuclei, some clusters of neurons in the brainstem, the medulla. And specifically, what initiates inspiration and expiration and sort of sets the pattern is this structure called the VRG, the ventral respiratory group. Ventral respiratory group of neurons contain the circuits that will send out signals to the integrating centers. Integrating centers are the place in our spinal cord that controls these muscles, right? So we're sending out motor neurons to things like our intercostal muscles and abdominal muscles and diaphragm and so on. Okay, there's a coordinating center in the spinal cord for that. Okay, so we can say that the VRG establishes the rhythm, and when there's inspiration and expiration, it sends out signals to the spinal cord that then control the muscles. Okay, so it's on, and we get inspiration. It turns itself off. Okay, it turns itself on, sends out signals, turns itself off. Okay, so it goes through this pattern of on, off, on, off. When it's on, it's sending signals to contract the diaphragm and perhaps some other muscles. And it's off, the diaphragm relaxes, right? So it's inspiration, expiration. And so it's, in some ways, you could think of this as being somewhat analogous to the pacemaker of the heart, right? It establishes its own rhythm, okay? But just like the heart, there are things that can influence the pacemaker, right? So here we have things that can influence the VRG, right? And those things are the DRG and the PRG. Okay, so this stands for dorsal respiratory group and pontine respiratory group, pontine meaning in the ponds. Okay? I don't expect you to distinguish between the two of these, DRG and PRG, other than to know that they send signals that will make adjustments to that sort of pacemaker activity within the VRG. Okay? But where do they get their signals from? How do the DRG and PRG decide to tell the VRG anything? Well, this is where we take in information from sensory components of our body. Okay? So we have chemoreceptors that tell us about the state of our blood chemistry. So we are interested in particular about pH and CO2 and O2. Okay? So what if O2 is low? What would you expect to happen to our breathing? Right, for low O2, we would increase ventilation. Sorry. Ventilation. It's falling off the page. Okay. So, what if we had high levels of CO2? Same thing. We breathe more rapidly and get rid of that extra CO2. Okay. Did we talk about pH? How does pH relate to CO2? Whenever CO2 goes up, what happens to your pH? It goes down. Blood becomes more acidic. Okay. The reason for that was in the reading today, but we'll get into that a little bit more. Okay, so chemoreceptors tell us something about whether or not we have sufficient oxygen or whether we have too much CO2. All right. What's the difference between a central and peripheral chemoreceptor? Central is located where? Okay, peripheral is located where? Where do we have peripheral chemoreceptors? The aortic and carotid bodies. Remember those things? Those same things that told us about CO2 and O2 in the blood for the purposes of adjusting blood vessels and heart rate? Okay, same things. Those are peripheral chemoreceptors. So if they're peripheral and they're in blood vessels, we're central. Vessels in the brain. Okay, so this has to do with the brain, central. Okay, so the information there about the gases of blood influences our respiratory rhythm. Okay, a stretch receptor tells us when we have inflated our lungs too much. Okay, an irritant receptor tells us that we're breathing something that we should not be breathing. Okay? Stimulation of either of these would diminish your rate and depth of ventilation. Okay? Proprioceptors are little sensory endings we have in muscles and joints. They tell us how our body is moving and how our body's positioned in space, even when our eyes are closed, right? So we don't have to know where our muscles are in space in order to move them, right? Because our brains know, right? We have a sense of our body's position. So how are these used? Well, when you start moving your muscles and joints a lot, that's a good sign to your brain that you're going to need some more oxygen, right? So proprioceptor stimulation, which happens with movement of the body, leads to increased ventilation rate. Make sense? Yeah. Okay. I like it when people leave right after the first poll, because there's not usually a second one. I know it's locked.
No, I have a question.
Okay. I thought you did, yeah.
Could you go over the stretch receptors again?
Stretch receptors? Sure. Stretch receptors are receptors that are in the lungs, and they tell us when our lungs have been stretched too far. Okay, so if you inhale and inhale and inhale, you'll have this urge to stop inhaling and exhale. And that comes from your Schett receptors.
Okay, and then also irritant receptors, or they tell us when we're breathing something that we should not be breathing.
Yeah, irritant receptors will tell us that there are chemicals that could be harmful to us, and it causes us to breathe more shallow. All right, take a minute here and see. This one's going to be pretty fast. Let's take 2 minutes after you're done already. Anybody need more time? No? Okay. Okay. Exercise. Exercise stimulates what? Does it stimulate chemoreceptors? Maybe eventually. What? Proprioceptors, right? Proprioceptors will tell us that we're exercising. They'll tell our brains that we're exercising, in case it's not obvious. Okay? And it's this information that really has a powerful effect on increasing our rate and depth of respiration. Okay? So when you start exercising, your brain knows it, not because of what it sees, but because of what your muscles are telling it. Okay? And that is used to make sure that there's enough oxygen flowing to your exercising muscles. Okay? So exercise will stimulate that. All of these other things would have the opposite effect. They would depress the rate and depth of breathing. Okay? Low CO2. No, it would take high CO2 for us to increase our respiration and get rid of that CO2. Low would do the opposite. Formaldehyde exposure, start breathing in some fumes of something that's not good for you. You start breathing more shallowly and not as often, okay, to protect yourself. Okay? And high blood O2 would slow down breathing. Okay. So for today, and we don't have class Friday, and for Monday, today and Monday, we are going to be talking about this topic. And then you know what happens? The test. I'm excited. I hope you are too. Test is on Wednesday, correct? Yeah? Friday? No. Tomorrow? 2 days from now? You could probably fool me that way. You probably could. I never know what day of the week it is. It's my single fault. All right, so let's talk about gas exchange. So we've been talking about ventilation all this time. And we've talked a little bit about respiration, the movement of gases. But largely, we've focused on ventilation. So this is where we both have to get really broad and discussing things, but then we'll also get a little bit more into the chemistry as well. So we need to know what's in the air we're breathing, right? These are the major gases that we care about. Nitrogen, because it's the most abundant, but it doesn't do anything, so we don't need to worry about it. But it is the most abundant, so we should mention nitrogen. Oxygen, also very abundant in the atmosphere, making up about 20% of the air we breathe. And then water vapor as a gas is a very small amount, and CO2 as a gas, a very, very small amount, but rising in the environment. We have this air that we are breathing, okay? And we have Dalton to thank for Dalton's law, okay? So when it comes to the impact of these gases on the movement of a gas into our lungs, we have to consider how much of that gas is in the air. Okay? It turns out that the proportion that a gas takes up in the air, in this case oxygen is 20%, it contributes that much to the total air pressure. Okay? So if air pressure is 760 millimeters of mercury at sea level, 20% of that pressure, of that air pressure, is due to oxygen, or 20.9%. Okay? So Dalton's law tells us that. All right? And this is important because it's the pressure that the gas exerts that has to do with why a gas moves into solution, or out of solution for that matter. Okay? Okay. So what we're dealing with is a pressure of about 150 millimeters, 160 millimeters of mercury. Okay? This is the air pressure that we have around us that is owed to oxygen. Okay? It's because of oxygen we have 159 millimeters of mercury. Okay? There's math here, but we're not doing the math. All right. Now let's take a look at the air that exists, not in the atmosphere, but the air that we find in our alveoli. Okay, so if we were to take an average sampling of the air that exists inside of our alveoli, we'd find some different values. Okay? So let's stick with oxygen because we like oxygen. Why on earth would oxygen decrease in its partial pressure as it moves into the alveoli? As that air comes into the alveoli from the atmosphere, why would its partial pressure go down? We can say, well, clearly its percentage has gone down. Okay. Well, let's use that then. Why is the percentage of oxygen suddenly less? Yes?
Because the proportion of H2O and CO2 went up.
All right, so H2O went way up. Why does H2O go up? There's a lot of water vapor in there, right? It's pretty humid. Lots of water vapor inside of your lungs. Where's that water coming from? Your tissues, your lungs, right? Your lungs are, as tissues, are giving up water. Okay? All right. So H2O's gone up. Carbon dioxide's gone. Why has carbon dioxide gone up? What do you think? Why does CO2 go up inside our lungs compared to the atmosphere? Metabolism, right? This CO2 is in our bodies, and it's coming out and going from the blood to the alveoli, right? And so when we breathe in atmospheric air, that atmospheric air is mixing with air that's already in the lungs, okay? So we don't expel all of the air in our lungs when we breathe out. So there's some there when we breathe in. And whatever comes in from the atmosphere is mixing with what is already in the alveoli. Okay? So we are down to a value of 104 as the partial pressure of oxygen in the alveoli. And this is what we care about. We don't care what's in the atmosphere so much as what's going to directly impact respiration. Okay? What directly impacts the exchange of gases is that partial pressure of oxygen in the alveoli. Okay? All right. You with me? Okay. So why do we care about oxygen's pressure? I like this guy's hair. This is Henry. He's got both the rooster thing going on and lamb chops. That's cool. See that? We got the, and then the, yeah. It's a good combo. So why do we care about this? Why do we care about partial pressure? This is Henry. Hi, Henry. Henry's law. Henry's law tells us that the partial pressure, not the concentration exactly, but the pressure, the amount of force exerted by that gas, let's say oxygen or whatever, is the determining factor, or one of the determining factors, in whether that gas moves into solution, right? So when oxygen goes into blood plasma, right, it is going to be a dissolved gas. That gas is going to exist within the blood plasma. Okay? So it turns out that it's the pressure that's provided here that determines how much is going to go in. So if we had a little plunger here, right, and we added more pressure, okay? We're not talking about the concentration. If we increase the pressure, more of that oxygen would go into solution. Okay? So when it comes to this movement of gases, it's not simply about diffusion. Okay? At least not here at the lungs where it's going from air to liquid. Right? It's about pressure. Okay? So partial pressure is the determining factor of whether a gas moves in to solution. Okay? What's another factor? Anybody know? Solubility. Okay? Solubility is a very important factor. Okay? What's a more soluble gas, oxygen or carbon dioxide? Anybody know? It happens to be carbon dioxide. Okay? Carbon dioxide likes to be in solution. Oxygen, not so much. Okay. So that's an important factor as well. Okay. So here's a little illustration to show what I was trying to say. We've got some sort of gas that's at a particular pressure, and on the left there. It's going to dissolve into the liquid according to its partial pressure and its solubility. Okay? If you increase that pressure, you will increase the number of molecules of oxygen that get pushed into the air, from the air into the liquid. Okay? So it's the partial pressure that we care about, and it's a little bit of an awkward thing to be talking about because we so much want to talk about concentrations, because that's what we learned about with diffusion, that sort of thing. But this is not exactly diffusion. This is moving a gas into a liquid phase. Okay? All right. So the relationship here then is that we are next time going to talk about an alveolus. So let's do that. Here's an alveolus. Okay? And we have a partial pressure of oxygen inside of that alveolus of what value? 104. I don't ask you to know a lot of numbers, but I want you to know this one, okay? Okay. And, of course, there's going to be blood traveling by in a capillary. Okay. Right side of the heart, pumping this deoxygenated blood. Okay. And so when the blood goes by the alveolus, that blood is going to have a lower partial pressure. Okay. We might say its value is about 40. Okay. And so what will happen is that because of the pressure that exists in the alveolus, where that 104 millimeters of mercury is pushing on the walls alveolus is going to push its way into the blood. Okay? Right there. What would that space, that plane be called where they interact? The respiratory membrane, right? So we have the alveolus interacting with the blood, our respiratory membrane. And it's going to move from oxygen is going to move from 104 in the direction of where the partial pressure is lower. Okay? All right, so we'll pick up there next time. And we'll talk about how we're moving gases and then how we transport them. Okay?